so tied up with this insurance companies. You cannot order this test. You'll have to do this first. You cannot prescribe this medication. You have to try the generic first. Try it for like 3 months. Switch to the higher dose. Switch to another medication before you could get to this, final medication that was our, target. Very, very hard. We, in the renal community, we have a Renal Physician Association, and we are in constant, touch with the Congress, where I even went to the Capitol Hill to do the testimony on that. We send the patients. That is more effective. We send the patients to the Congress, and they, testify. They wanted this particular medication, and mostly it is one of the medications that we use a lot in the kidney diseases, which is erythropoietin. It is very expensive. It is very expensive, and it is very necessary. It is like $2,000 for a month's supply or something like that. It is tough. It is very tough. So far.
My question is really.
No, I'm saying add on to Ashmani sahab, tahan jo jawab na jawab ne jo. See, in a training in medical school, what's the tragedy that we don't get trained how to run your practice. Over the period of time, we've been hijacked by the corporate America, like another corporation. And we as a physicians, most of us, we are employees of hospital or corporates. And those corporate CEO, they get so many freebies, they don't work, but we are working for them and we are making for money. That's where the problem is, that we don't know how to run the business. They have created so much fear in physicians of malpractice, and the attorneys, they love, and that what has called, if you remember, I clearly remember instead of the Union address, second time, 2 years, if not 3 years in a row, our President Bush mentioned, when it came to the healthcare issue, he said, this should be between doctor and his patient, or patient and his doctor. Does it follow through? No. And this is a corporate America like another business. We are poor administrators. Whoever the physician, very few I know, I don't want to take name, and they have started their own practices. They are doing better, but always their fear of unknown, that what have created in us, and we have just sat back, and we have just not, I just wanted to add something to it.
And your question was that why we are number 37. The reason is the blame game. Doctors blame insurance blame doctors, and this is a capitalist system which is inherently corrupt. It's an all economical issue. Doctor wants it. Because there's a pie, you are going to share from that pie, healthcare pie. Doctor wants to grab more. Nobody is concerned about the patient. Bottom line is how much money I should make. Insurance company, doctor, hospital,
So
there's no.
Are you supporting a nationalized?
Of course.
Let me tell you. Let me tell you what.
That has inherent
One
problems.
at a time. Let's add on Dr. Turk.
Okay. I'm on the hospital committee's director of the cath lab, and we always go, and I'll tell you that the system is driven by the numbers. Every hospital wants to do a certain number of surgeries, certain number of admissions. If you look into academia, having more admissions in the hospital is a negative outcome. You want to decrease admissions. Having more procedures and more surgeries is considered as a negative. You want to prevent the surgeries. Having more office visits is supposed to be bad. You have to decrease the number of office visits. But in the economic world, it's just other way around. They want to know, well, last year our number of CAT scans were so many, we want to go up by 10%. This is a goal. Our hospital beds have to go, our occupancy has to go up. This is constantly driving the physician, so the physician even loses the sight of the whole problem. I think the problem is not only with the physicians. As my brother said, that there's so much pie. Insurance companies, the technology companies, the consultants, the lawyers, the attorneys. concern is everybody wants a piece of the pie, and nobody is really looking at the outcomes. I don't think we've got a bad healthcare. I don't think the outcomes are as bad, but the system is driven by the numbers. Until there's a national health system where you have to go back and say, if you reward the physician, say, okay, if the number of the surgeries go down by so much percent, you are going to get a bonus. You'll see what happens. Automatically, the number of the surgeries are going to go down.
It is coming up. Payment for performance is coming up. It's in the Senate right now. So hopefully by next year, January.
Yeah.
I have a question on the diabetes.
Yeah.
You know, what is the critical range where you have a diabetes or pre-diabetes and your blood glucose sugar? Because the numbers keep changing now. They grow 100 is the you have no diabetes. But really, the clinical labs, they have a lot of built-in error. So what's the really critical range that you're free of diabetes or you are pre-diabetes?
Right. I think as far as I understand, and may have changed recently, the fasting blood sugar level from 90 to 110, it is considered as normal, as far as I know. And if it is 2 hours following, meal, then it has to be 140 or less.
No. According to new ADA, American Diabetic Association, you are normal range. Now ADA has become, American Diabetic Association have become very strict. They say that you have to diagnose sugar very early because in a retrospect, and you're right, and it takes them 30 years to realize uncontrolled sugar in the long term was causing more heart attack and stroke, was causing more cost on the healthcare system. So from 140 it's not, it's 126 and above, you are diabetic. 2 fasting consecutive blood sugar 126 and above, you are diabetic. Fasting.
Postprandial.
Postprandial.
140.
That's what you said.
Postprandial.
Postprandial.
I said postprandial.
Postprandial.
And the fasting I said actually 90 to 110.
You know, this is that's normal, which you say. But 100, it used to be 140. Postprandial. So that's what it is now. There used to be either you are diabetic or you are non-diabetic. Now it has become a criteria that you are a non-diabetic, you are pre-diabetic, then you are a diabetic. So when you are pre-diabetic, then basically you start treating patients at that time to delay the diabetes. Azubali wants to say something?
No, I have a question. You finish it.
No.
So basically, I hope we answered your question.
No, you didn't.
You didn't, right?
You didn't get. Did you get it? No. I got the normal range, 90 to 110. But you were saying
There's nothing
pre-diabetic.
pre-diabetic. I mean, you are either a diabetic or you're not a diabetic. There was a gray zone of glucose intolerance that they try not to talk about now. If you become a diabetic, it's not necessary that you go on medicines when they diagnose you with the earliest stages of diabetes. You may do all kinds of other things, but you're not a non-diabetic. You are either a diabetic or you're not.
It's just like you are
So the
either a
glucose
pregnant or
tolerance
not
test
pregnant.
Is no good? Is that what
That's
you're
it.
saying? They do glucose tolerance tests.
You're pregnant or you're not pregnant, that's it.
That's it.
Glucose tolerance test.
Very few cases that you need a glucose tolerance test.
Glucose tolerance test is fine. Jagannath sugar fasting is 110 or 120, they will do the challenge, glucose challenge. If your sugar fasting is 150, they don't even proceed towards the challenge. Means they go according to the criteria of fasting. If you are 26, 126 and above, they are not challenging in my hospital. And that's basically, as I said, that has become very strict, that you put patients on the medications sooner the better to get the late side effects, of coronary artery disease and stroke, and save money in the long term from the disability.
Okay, I got a psychiatric question too. Go ahead.
Go ahead.
The